right, thank you for everyone who's joined us and for your patience as we figured out our technical snafu there. This long into the pandemic, you'd think we'd all be experts at Zoom, but we're still getting it figured out. Anyway, welcome to the Society of Academic Emergency Medicine's Research Learning Series, or RLS. My name is Cole Lettingoff. I'm a medical student at Trinity School of Medicine, and I'm delighted to be moderating this session on implementation science. It is a topic of undeniable importance, but unfortunately one that many of us have only a general understanding of. If you're like me, you probably think of implementation science as a study of how things get implemented, and probably don't know a whole lot more about it than that. I have been told on good authority that there is quite a bit more to it than that, and thankfully we've got two real experts in the field with us today to help get us up to speed. Allow me to offer some brief introductions before handing it off to our speakers. We will have time for questions towards the end, so for those of you who are joining us live, please feel free to post questions in the chat. For those of us who are not joining us live, consider it next time. It's a lot of fun. Without further ado, our first panelist is Dr. Christian Pulcini, a pediatric emergency physician at the University of Vermont Medical Center at UVM Children's Hospital, as well as an assistant professor of emergency medicine and pediatrics at the University of Vermont Larner College of Medicine. He attended Tufts School of Medicine, followed by a pediatric residency at Children's Hospital of Pittsburgh. He then completed pediatric emergency medicine fellowship at the Children's Hospital of Philadelphia. He also holds a master's in education and secondary education from Loyola Marymount and is a former Teach for America Corps member, and an MPH in maternal and child health from Boston University School of Public Health. His current areas of research focus are emergency care of children with medical complexity, firearm injury, and acute mental health. He is currently funded by an NIH K-23 Career Development Award entitled Optimization and Implementation Trial of his user-centered emergency care planning tool for infants with medical complexity, of which he aims to become an expert in implementation science and clinical trials while focusing his research and transition to research independence on improving emergency care of this particularly vulnerable population. Beyond the focus of his K-23 award, he also has a passion in closing both the evidence to policy and evidence to practice gaps as it pertains to firearm injuries and acute mental health for children in the US. Joining Dr. Pulcini is Dr. Kabir Yadav, the Vice Chair of Academic Affairs and Associate Professor of Emergency Medicine at Harbor UCLA Medical Center. He completed emergency medicine residency at Kings County Hospital Center / SUNY Downstate Medical Center, followed by a clinical research fellowship at Jacobi Medical Center with a master's in clinical research methods. After completing an NIH KL2 Career Development Award and a master's in translational science at George Washington University, he became one of the first board-certified clinical informaticists in the country. He is core faculty at the UCLA CTSI for both the Community Engaged Research Program and Biomedical Informatics. He has also been funded through PCORI, NIH, CDC, and foundations to leverage technology and implementation science to perform collaborative health services research focused on improving patient and provider decision-making, and partners with community to do mutually meaningful research with an emphasis on social determinants of health. Thank you both for joining us and sharing some of your experience with us. Dr. Pulcini, I believe we're starting with you.
Thanks so much, Cole. I thought you said those introductions were going to be like 10 seconds. That was very humbling and interesting to hear, as always. Hi, I'm Christian, everyone, and happy to be talking with you all about implementation science, the why, what, how, and when to utilize implementation science with a specific twist for emergency medicine physicians. I think we're going to sort of scratch the surface here today on implementation science, and hopefully there's not a shroud of mystery surrounding the words implementation science after we get done today. As this introduction will hopefully show that this is a very practical methodology to use in emergency medicine, especially in the systems in which we all work, which, as we all know, are not always the cleanest systems in which to implement and run things, as predictability sometimes eludes us. That is us. We've already been introduced, but I do want to certainly give a lot of credit to Chris Carpenter, Liz Samuels, Janet Lynn, Kim Stanford, and Kieran Fiar, because they helped us do this didactic at the SAM meeting a few weeks ago now, and helped us develop a lot of these slides that we used. And obviously they offered their permission, but a lot of them are excellent experts, and if you know any of them and want to reach out, I'm sure they'd be more than happy to field questions as well. Disclosures, the NIH funding that was already alluded to, and then the Pediatric Pandemic Network is something that I'm consultant under to do disaster preparedness, specifically as an implementation scientist. Our objectives today are to describe implementation science. Once we say the words conceptual frameworks and strategies, people get intimidated, but I promise you they'll make sense. And Kabir will do a wonderful job of leading us through that part of it. How conceptual frameworks can be applied to emergency care research and operations, how to design rigorous interventions, including advanced and emerging concepts, and then identifying opportunities for external collaboration and funding, which are the things that help sustain a lot of our careers when we're in this field. So as an agenda, so we're going to do an intro to implementation science, which I think will be very high yield for a lot of folks. It will involve what's implementation science versus QI, as well as with emergency medicine, frameworks and key points, and then some emerging concepts and pain points, and then some additional resources that you can all use for those who are joining us synchronously or asynchronously. The entire thrust that I have learned of implementation science when we think about an overview is that many years ago now, it was identified that there is a practice to implementation gap. And that practice to implementation gap, believe it or not, is estimated to be 15 to 17 years. So if you look at the clinical implementation gap, as it's called, that medical knowledge seems to increase and what we actually apply lags behind it by a very long time. I mean, 15 to 17 years is probably half of our careers in emergency medicine, and that's how long it actually takes for upkeep. And implementation science was born out of the thought that we should try to close this gap of what we know and what we apply. And so it's all about incorporation of evidence-based practices into routine practice and not making it happen 17 years later. When the highest level of evidence can be found, randomized control trials, meta-analyses that show really impactful clinical applications. Unfortunately, our actual practice in medicine and emergency medicine often lags behind that because of implementation barriers and getting it to actual application in real world settings. That's what implementation science is all about. It's honestly pretty straightforward. And doing it in a scientifically rigorous way, that's where all the frameworks and strategies came out of. And the whole point of it is to improve the quality of health services and care, which we all know is an ongoing struggle, especially in the emergency room where we're trying to constantly keep up on evidence and implement it into practice into systems that are sometimes challenging. So implementation science is geared to help close that gap I was talking about and improve the quality of care. So this is a fine line, the difference between quality improvement and implementation science. This is something that I'm frequently asked, notably in my own institution as a smaller institution where implementation science is quite a novel concept. So if you look at quality improvement on the left, so it takes a specific patient level problem within a single healthcare system. And the goal is to fix that problem within a single healthcare system. And you design and trial strategies to improve the problem, use things like Toyota Lean. Implementation science, where it starts from, it's not like a patient level problem where it begins from. So I think of QI as broader. Like this could be any problem. It could be an operations problem, something that there's not evidence that currently exists, and it goes to solve that problem. Implementation science starts with an evidence-based practice that is underutilized, and that's the thrust of it. So it's more narrowed to interventions and applications that already have some evidence base behind them. And it's not necessarily to help improve a process, so to speak, in the emergency department. It's to generate generalizable knowledge while also improving healthcare quality, also designing and trialing strategies to improve the problem, use things like re-aim, which I believe we're going to go through a little later. The thing about implementation science is you always have to start, and just to point out, I'm going to make a conceptual sort of difference that I'm often asked is efficacy versus effectiveness is important to understand. So efficacy is establishing that this can happen in sort of an optimal setting, whereas effectiveness is more about real world settings. And so implementation science deals a lot with effectiveness, which is how does this actually play out in real world settings? So effectiveness research asks whether the thing works sort of in real world settings. An example of that in my research would be years and years ago, this emergency information form was thought to be a good solution to children with medical complexity presenting to the emergency department, which we all know what happens when children with medical complexity come into the emergency department. Everyone gets real nervous, parents are nervous. It's not a great time for everyone involved, and there's a lot of challenges involved in caring for that particular population in emergency medicine. The problem with it is it was a static one-page form that wasn't really human-centered, didn't use like human-centered design, so it wasn't designed towards the end user. They tested that in simulation settings and found that it was efficacious. So in the simulated ideal scenario is efficacious, but the effectiveness of the actual intervention has never been tested in real time because there's so many implementation barriers. So implementation research asks how to best help people go from the thing to actually getting it in practice. And so, for example, the example I just gave is how do we actually meaningfully implement emergency information forms for kids with medical complexity and prove that they're actually effective in real-time practice? I love this subway line of translational research, which sometimes is hard to follow and also helps that I told you about efficacy and effectiveness. So you have an intervention or a practice of interest where you're not established that it has an evidence base yet. Because the first question is, has the intervention or practice of interest shown some efficacy in even optimal settings? And if it's no, then that's where it goes to efficacy research. You have to establish that it's efficacious. You go to the next one. If there is some research that is efficacious, has the intervention or practice shown effectiveness? And I'm sort of going down on the right here. And if it's no, then you have to do some effectiveness research. And then you have that no, like partial sort of effectiveness. And that's when something called hybrid effectiveness implementation trials come into effect. Just so you know, this is currently the work that I'm doing. I made a modified emergency information form and I'm going to implement it in practice while measuring both implementation outcomes, like is this acceptable to the people that use it? Is it feasible? While also measuring health service outcomes with that modified emergency information form. So that's kind of where I am with my research, is right in the middle of that graph, right in the middle of this subway. And if it's shown effectiveness, then it goes down to the bottom, where you often are doing mixed method studies to understand the context in which you want to implement it, and then also kind of weigh out the implementation strategies in your local context for this particular intervention that's been shown to be effective. And you can see the bottom right is testing implementation strategies. So I love how also the colors, if you pay attention to those, you have efficacy, effectiveness, and implementation research. And how there's a merger there in that middle line, which I was explaining, is exactly where my research is. So when can you use implementation science? I will say that implementation science is extraordinarily effective to close that gap when you're planning an intervention or study, thinking about what is the context in which I'm going to implement this, especially because if you've seen one emergency department and actually thinking about meaningfully in a standardized sort of way through implementation science methodology, how can we best implement this here in our setting, can be really impactful and hopefully close that gap. Improving the effectiveness of an existing program, also true. I think we all know of programs that have potentially been attempted to be implemented and that implementation does not go as well as perhaps desired, that taking a step back from that and actually using implementation science principles may increase uptake of that particular intervention or success and adaptability. Scaling up programs, same vein I was just talking about, expanding programs to new sites, because you do have to understand the context a little bit if you are doing something in new sites. This is something I'm dealing with now as I'm trying to start to write my own R01. For me in particular, just to give an example, my fellowship, you heard I went to Children's Hospital Philadelphia. I'm trying to expand to a setting at Children's Hospital Cincinnati, which is extraordinarily different than University of Vermont, which is a general emergency department in a rural state. So there's a lot of understanding and context I need to figure out for that. And then evaluating programs, programs that are sort of ongoing. Implementation science can be used for that as well. There are evaluation sort of frameworks that can be used. This is the last slide, I think, for me, and I found this one really fascinating. Chris Carpenter presented this at our academic emergency, at the SAM meeting a few weeks ago, and I'm not sure I'll quite do it just like he did, but it starts at the top with that high quality, clinically relevant evidence. And you can see these sort of leaky faucets is where everything sort of leaks out in terms of implementation. And the challenges is that you are sometimes faced when trying to implement something in a system. And we believe that this is the gap that implementation science is trying to fill and trying to get at the goal, which you see at the bottom is optimal patient outcomes based upon available evidence. I'm not going to go through all of these, but like things like acceptance and awareness are extraordinarily important. Like awareness of the actual intervention or the like we know that every day we're sort of bombarded with journal articles that are high quality evidence, but actually having the time and strategies to implement them sometimes is very hard, especially in the local setting. If you go down to ABLE, when we go down this sort of pipe that is traveling down, you see resource constraints is one of them. I know that's something that I face in my general emergency department, like in a rural area who's sort of evolving into an academic department. We often have resource constraints. We also sometimes have skill competence as well in terms of getting the highly quality evidence to actual practice. And then people have to agree to it. You probably know that it might turn out that people might not always agree with the evidence that is emerging. that is certainly a discussion to be had. And then competing influence as well. And then when you look at adhere, patient compliance and for forgetfulness, we all know is an ongoing issue. So these are all the kind of ways that things don't actually get into practice, or the challenges that you might face. And implementation science is intended to sort of help address a lot of these issues and, again, close the evidence to practice gap. I found this, again, this was presented by Chris at our SAM meeting. I found this fascinating. He was telling us the story about how all of these really high impact studies about congestive heart failure were done. Randomized control trials showed efficacy and effectiveness. And then they reached back out to the sites who published these studies, and you could see that only 7 out of 15 were sustained after the research funding stopped. So when the active funding stream stopped, that was outside the United States. Up the top is in the United States, it's even worse. It's 2 out of 15 were sustained after research funding. So things that they found at their own institution to improve patient care were not being sustained over time because the grant mechanism sort of went away in the funding stream. And that shows where implementation science is also concerned with sustainability within a system and can help improve that. And this probably is a little discouraging to some of us, but this is what we should be aware of and what should happen, and where implementation science can play a role in, because it builds things into systems at the local context and local level. I'm going to let Kabir take over for implementation frameworks.
Thanks, Christian. So let's talk about these frameworks. So with the next slide, we'll just talk about again about what these frameworks are really driving. So they're really driving two things. So one is the behavioral underpinning that will drive a change in practice is one set of theoretical frameworks that are used in implementation science. And then the other set of frameworks are what allows us to analyze a practice to learn how the implementation actually worked, to create new knowledge to allow other sites or even your own site improve on that practice improvement. So the next slide is some resources about where you can go to find these frameworks. So there are 2 web links on the bottom of this slide, but these are ways that you can essentially look at what you're trying to do, plan out what type of intervention you're trying to implement, and then it gives you some suggestions on what types of models you would want to use to achieve your specific goals, keeping in mind that there's different types of implementation goals that you may have in mind. The next slide, again, kind of reiterates the types of frameworks that exist for implementation. So again, if you are looking at the evaluation of the implementation, those are more evaluation frameworks. That's on the far right, where we'll talk a little bit more about re-aim and some of the other ones there. The middle group is actually what influences the implementation. So this is the actual process of operationalizing the intervention, and those are the determinant frameworks, classic theories, and implementation theories. We will probably highlight CFER today. And then there are larger, more sort of academic approaches to these frameworks, which is the translation of research into practice. So these process models, which are the ones on the left. So let's go ahead and talk about one of the actual frameworks that help us understand how an implementation should be operationalized. So the consolidated framework for implementation research is looking at all of the factors that we probably would consider once we realize that something doesn't work, but you don't want to do that after the fact. You're actually going to do it ahead of time. And so what this allows you to do is you think about what it is that you're trying to change. You interrogate that innovation. You look at the context within which you're trying to operationalize something, both the outer and inner settings. You look at the people that are being either asked to do this or the people who are influencing that change process. And then you actually look at the actual process of implementation that you're going to undertake. The next slide kind of explodes this out into a socio-technical framework. This is the CFER framework 2.0. And what you can see there is that the outer setting, the inner setting, and the individuals is sort of the actual like social framework of the environment that you're working in. And then the actual thing, as Christian mentioned before, the innovation, you evaluate its particular aspects, and then you actually then look at the implementation process. So all of this is a lot. It's also can be pretty complex, but it is good to sort of think about it from a healthcare perspective. So the next slide really looks at some of the things that you would really operationally analyze. So the outer setting would be patient needs and resources, the sense of peer pressure, and any policies and incentives that are in place. When you look at the inner setting of a practice, you're looking at the structural characteristics, the organizational culture, their willingness to do implementation. The individuals, you look about their knowledge and belief about the intervention itself, their sense of self-efficacy to actually do something that's different, their stage of change, that their willingness to do that, how they align themselves with the organization, other personal attributes, and then the intervention, like this strength of evidence, whether it actually looks and feels to be advantageous to what is standard care, how it can be adapted to actually meet the needs in the local context, quality and packaging, sort of the shininess of the intervention, and then obviously the cost, how much it'll actually impact the bottom line. So that's one way of sort of framing what you're trying to do from an implementation framework of the process of creating that change. So when you talk about actually then doing it and measuring what you're doing, the re-aim framework is one that is pretty popular in emergency medicine. This is Liz Samuel's example. She's at UCLA, but her project is at Brown in Providence. And the re-aim framework is essentially keeping in mind that you need to both measure indicators that the thing you're doing is actually effective, right? So that's the reach and effectiveness measures in the acronym. And then you're also looking at process outcomes that actually indicate that the implementation is working. So that is the adoption, implementation, and maintenance parts of the acronym. So on the next slide, you'll see what some of those measurements would be for her project. So in this case, she's looking at reach. So this is a use of SMART community health workers. SMART is substance misuse assistance response team community health workers. So the reach would be the number of patients that are coming into the emergency department with a substance use issue and how many are actually being seen by the SMART CHW. The effectiveness would be, in a comparative effectiveness way, how the SMART CHWs are performing versus a community peer recovery specialist or those that aren't getting any counseling. Looking at adoption is looking at how many patients are actually willing to get that consultation from the SMART CHW. The implementation metrics are looking at the actual benefits to the patient. So these are the types of services that are actually being provided and the proportions of visits where the CHW is actually able to see patients. The maintenance is the stability of engagement by the SMART CHW. As one can imagine, sustainability is always a question when it comes to these things, that while you have everybody's attention and eyeballs and motivation during a study, it may work for a couple months, maybe even for a year, but then does it tail off? And so maintenance is a key aspect as well. And then that is what Smart Aim is. What Liz did, and in her proposal, but now actually has a focus of implementation science, is a look at equity. So she kind of integrated equity into her proposal at every level of the re-aim framework. There's a larger movement over the last couple of years to really talk about doing this in implementation science in general. So focusing on reach, making sure that it's getting to everybody where health disparities exist, designing the implementation with vulnerable populations in mind, potentially having community engagement or even CBPR type work. So having community participate in the design of the study. Then looking at strategies that have been shown to actually work in implementation to reduce inequities, have a science around the adaptation to meet said inequities, and then obviously have an equity lens when looking at your implementation outcomes. So you'll see everywhere throughout this framework that she's suggested that they'll evaluate for equity at each dimension, is what she did. Next is Karen also presented another approach to the re-aim framework, and this was looking at syphilis screening in emergency departments. So again, this is re-aim, just presented a little bit differently. This one has a wheel, but it basically is, again, the same ideas as to what you're doing here. You're looking both to see if the thing you're doing works. Did it reach people and was it effective? And then you're also looking at the implementation. So in this approach for this study, you can see on the next slide, it's a little dense. I would suggest you can look at it at the slide later, but essentially is looking at the same idea. The reach was the number of eligible patients that were actually getting screening before and after, looking at trends and variations and disparities of key subgroups. Again, the effectiveness is how many actually are getting screened and how many are actually positive. Adoption is looking at if there's any disparities in who's actually getting the screening. Are there differences across settings? And are there differences across providers? And then when looking at linkage to care as the actual so what, they're looking at the implementation of those particular linkages to care, and then maintenance is to see if this actually happens through the care course. And then finally, cost as part of the importance. So even if you don't necessarily know what the cost of your particular program is, if you're looking at cost as part of your implementation, then at least the next group of people will know how much it may cost them to try to embark on your particular innovation. Okay, so let's shift gears a little bit and talk about pain points. So I will say that the overall main pain point is that implementation science may just seem big and scary, and that really is the most important barriers to try to find people that are actually doing it. And we'll talk a little bit more about that. But the readiness to do it, honestly, is primarily driven by that subway line. The main thing is there evidence that the thing you're doing actually may work. If it does, then you may continue with an implementation framework, and then that requires that understanding the context within which you're running. So that's where that CFIR approach would be one way of understanding the context of your socio-technical system that you're trying to achieve a change in, and then making sure that what you're doing actually is the thing you set out to do. That's fidelity or adaptation. And then doing the cost analysis is going to be, particularly in the American healthcare system, is going to be very important to know how much resources are going to be consumed to achieve said ends. And then the other thing that wasn't really in these frameworks per se, but is unintended consequences. So understanding that you need to also look every time you try to do an intervention in a new place, are there unintended harms that are being brought on patients or staff? The next slide is really just, again, kind of reiterating when to consider doing implementation. So again, it's the 5 Ws. Is there a need to embark on this? Does it make sense? And as long as those two things are met, then you can tackle the 5 Ws, which is, again, the same sort of implementation frameworks like CFIR, where you look at the who's, the what's, the where's, the when's, and the why's. The how, again, is the actual implementation process, which we highlighted above. And then coming back to the actual fidelity and adaptability, and this is one of the things on the next slide that is really one of the main drivers or differentiators between QI and implementation science, is that QI has a tendency to try to break it till it works. And so then it's likely that whatever you ended up with wasn't really what you started your intervention on, but you just iteratively refined it and changed it and made it work. But if you aren't paying attention to how that's changing and why it changed, then it's going to be very hard for you to explain to another site or another health system what actually worked and how the end result of what you actually used as your intervention worked. So that's where the data comes in for fidelity and adaptability. You have to measure these things, otherwise you won't really know why something worked, or more importantly, or just as important, if it didn't work because the implementation went awry, or was it that the actual intervention itself wasn't effective? There's an interesting study, well, more of a hypothetical study, that looked at if a particular intervention was 50% effective, but the acceptability was 50%, the adaptation was 50% impaired, the penetrance was 50%, like every implementation thing was also 50%. By the time it actually impacted patients, it was 1.5% effective, because every one of those implementation inefficiencies was reducing the actual benefit to patients. So it is important to be mindful of how you're doing the implementation, because maintaining the effectiveness of the implementation is as important as the effectiveness of the intervention. I won't belabor the funding too much. It's in our resources document, but there are different ways to approach getting the implementation aspect of work funded. Larger health systems do have some sort of implementation team or resources for healthcare improvement. Sometimes you just have to figure out what the names of the thing is, but that's obviously the lowest hanging fruit, is when you can actually ally with your patient safety or quality improvement or some other group that has talent and resources to put to good use. Foundations are also interested in this, particularly ones that see healthcare inefficiencies, who are, shocked that the fact that no established innovations don't seem to be operationalized. And then at the federal and sort of bigger pocketed groups than IHH, RQ, PCORI, have an interest in implementation science, and there's actually specific RFAs and scientific resources that they've published that's are bolstering their commitment to seeing implementation science in funded projects. The next page has some QR codes, so I would recommend you take a look at these. So the resource document is the one where I think a lot of stuff that will be more takeaways from this talk to sort of get started with implementation science or to find more resources for it. So the document has opportunities for education and training, both in person, but primarily virtual or asynchronous. Some useful textbook that some of our expert panelists had suggested, some tips and tricks about how to find collaborators or groups that can do collaboration for your implementation work, funding suggestions and opportunities. Some of the resources that we highlighted here are also there for the IS frameworks and resources. We didn't get a chance to highlight here. It's definitely Chris Carpenter's baby, but the standards for manuscript reporting for implementation science is the STARI framework. It is undergoing a revision actually this week, so hopefully look out for that. But the standards for reporting, which are on the Equator website, so you guys may be familiar with the Consort or Squire for QI work. So those frameworks for reporting are also good guides to think about how to do the science well. We also list some journals that are friendly to implementation science manuscripts, as well as conferences that are interested in showcasing your implementation work. So those are the useful documents and materials in that resource document. And then members of this group have presented at SAM, not just SAM 24 before. And so that link is to the YouTube playlist with some of those recorded talks. The one that we are primarily reviewing for this RLS hasn't yet been published, but will be, I think, in a month or two. So look for it on this link as well. And I think that's it, which gives us a little bit of time to take questions, hopefully.
Absolutely. And again, if you've got any questions, please feel free to post them in the chat. Got a couple that have already been sent in here. First off, thank you both for talking with us. I know it's a lot of ground to cover to introduce a whole field of study here. You did a great job. I think it's interesting to note that the start of this conversation focused on there already being an evidence-based practice that was not being implemented. In your particular institution, that was sort of the start of a implementation science inquiry. I've noticed that when we have these conversations, some of our institutions sometimes perk their ears up and get a little nervous about this notion of acknowledging there may be something that is evidence-based, maybe something that is the standard of care even, that is not being done at our institution. I'd be curious if the two of you have felt some of that pushback or fear of acknowledging that there is good medicine not being done when you want to do an implementation science study. Kabir, why don't we start with you on that one?
Sure. So I think so I work in a fairly resource-constrained public hospital system. I think generally you kind of have to meet people where they're at. So the things that they acknowledge are pain points or deficiencies, you have to figure out where and how you can, and this is somewhat adaptation of your implementation, but you're figuring out what can change, who you can partner with as stakeholders to actually get to the goal of improving care. The tricky part ultimately is it going to be too resource intensive to actually be feasible. But honestly, if it cannot happen, then that is, you aren't going to implement it, right? But that's part of the implementation process, is to figure out if it's feasible, right? That's actually one of our metrics. So understanding that you're working in that complex socio-technical system, when you're looking at the inner and outer context and you're looking at the people, you have to do that. That's part of the preparatory work. It would be, I think, both morally wounding to your workforce if you told them that they had to do this thing that's a standard of care, but oh, by the way, we don't have the resources, manpower, or interest to actually get it done. Like, don't do it. Like, why would you do that? So I think you have to be very careful and conscious about what is feasible. And that's actually part of the implementation approach, is to understand that as well.
I actually recently faced this with because I'm in pediatric emergency medicine, as I was introduced, probably got that by now, that the American Academy of Pediatrics came out with new febrile infant guidelines on how to treat a febrile infant when they present to the emergency room. And what interesting thing that we found with trying to implement it across the health network is that one example would be that some of the decision making, and perhaps the best biomarker for sepsis came out to be procalcitonin, but procalcitonin is actually not available at several of the hospitals in our health network to when they're evaluating febrile infants. So that's about meeting people where they're at and figuring out different rules and guidelines to actually implement meaningful evidence that comes out. And that, I think this does happen all the time. I think Kabir is absolutely right with resource constraints. I will take this one step further. One thing that I have found that's even more challenging that we didn't touch on today, and what I find fascinating, is implementation science also deals with de-implementation of non-evidence-based practices. And there are emerging grant mechanisms and all sorts of people who are interested in that practice. I don't know much about pulmonary embolisms, to be honest with you, but I hear some pretty vigorous conversations amongst our faculty in EM about what they do to evaluate concerns for pulmonary embolisms and the evidence that's sort of thrown around. And I do understand that there are some non-evidence, and there are actually grants and funding mechanisms and support out there to meaningfully assess and de-implement strategies that are known to be non-evidence-based but persist in practice. And I do find that particularly fascinating and something that might make some folks uncomfortable. But as Kabir said, part of the whole thing is these mixed method studies to sort of understand the local context and to meet people where they're at. That's the whole point of some of those. And with all of that combined, I've not faced extreme resistance in the approach, as long as you have to know that you have to be flexible and hopefully continue on the mission of closing that sort of evidence to practice gap, and also at times de-implementing non-evidence-based practices.
Continuing on this theme of sort of finding partners within your institution to do implementation science, you mentioned earlier in the presentation this distinction between sort of a QI, QA mindset and implementation science. And I know that all too often we throw out those terms like QI, QA, not always in quite the correct circumstances. Do you find that those folks who may be under those sorts of QI, QA umbrellas are good partners in this process? How much of this sort of framework, the things like the re-aim, the models that we discussed here, how much of that do they really even need to know about or understand before getting started in some sort of implementation science conversation?
Yeah, it kind of depends on what kind of practice environment you're working in. But thinking about it from people having to wear various academic hats, I think the easiest one is that in all likelihood, folks that are in admin or in operations who also have academic appointments need to publish, and it's sort of a thing that they know they need to do, but don't really have the bandwidth or necessarily the interest to do it. So partnering with them to actually help them get things published by doing higher quality work, publishable work, is definitely a way to find that alignment. The other thing that we did, which definitely I think made this more doable, was that if they are doing purely QI, so not to get implementation work done, but to actually at least facilitate with them, we created a fast track process in the IRB that if it is just QI work, even if it is going to get published, it does not have to go through IRB review. So that made them sort of get their appetite to publish QI whetted. And then once they see that implementation science very much can be a sort of a more rigorous approach to high quality QI, then it sort of brings them on side better because they realize that they can do more and have better reach if they're able to adapt and improve their QI into an implementation work. The second thing is to actually look at what the hospital's annual goals are or mission alignment, and try to find those folks as well. The other thing outside of QI or patient safety even is to look at other departments. And I think particularly nursing that may have academic leadership or a nursing doctorate program, like they're people that are actually trying to do academics in nursing. And if that's an opportunity, or social work is an opportunity to actually partner with people in doing the kinds of health services implementation that you're trying to do, then that becomes a win-win. Then you have resources and partners that are, trusted agents for your stakeholders that can help you actually get the project launched.
Out of curiosity, do your implementation science studies often fall under that QI accelerated IRB review?
So QI wouldn't. I mean, an implementation project wouldn't fall under QI because of the mixed methods, the other mixed methods things. We do have a framework for QI that specifically wouldn't allow implementation work to work because it doesn't have the, I guess, not to be pejorative, but the lack of methodologic rigor of QI is what allows it to be QI. And so by that very nature, it wouldn't fall under research, and implementation science is research. So it wouldn't qualify for that exemption. or it's not even exemption, it's not human subjects research. That's the determination that our IRB does for QI.
Out of technical nuts and bolts, we have the same thing with QI and our IRB. I think most are recognizing that, but the implementation science stuff I do does require an IRB. And Cole, just to reiterate your question, because I think Kabir added it pretty well. You're asking is how much do people actually have to know about implementation science that to like go about doing this?
Sure, I have to imagine that as you guys start talking about some of these things, it may take a little time to explain the frameworks and how this process works and why this is different than QI/QA. Is that something that, does that distinction really matter to many of the stakeholders you engage with?
I'm the one that is like funded to do this and responsible for it, but I will tell you that the level of understanding of a lot of people that I collaborate with is probably not very high. I think they recognize the goal of what I'm doing, but I'm not sure they understand exactly I'm going about doing it. So for example, there's pretty good guidelines on supracondylar fractures in kids and how to address them. And I found when I came to Vermont that they weren't always utilizing the most evidence-based practices that are out there, but had the capability to do so. And it actually served as a good collaborative model with our orthopedic group in the emergency room, which we hadn't really explored much before, those types of collaboration. So I've actually found that implementation science has sort of opened up some collaborative opportunities across departments and disciplines, like Kabir was alluding to, especially with nursing, with doing this. But their actual working knowledge of the orthopedic surgeon I was working with to implement evidence-based guidelines for supracondylar care was probably not, I don't think they could tell you about regain, but I think that they could probably tell you, because clinicians tend to completely understand the fact that we have this evidence out here and it's not being practiced and we probably should do something about that. That's the message that I just keep reiterating that sort of gets people to jump on board, and they're like, yeah, you're like, your mixed method study, you keep doing your thing. I tell them about all this, but do they have sophisticated knowledge of implementation science? Maybe not, but I will say that the approach is probably what made some of these things successful, regardless of some of the key partners like knowledge of it intimately.
I think it leads nicely, and it will probably be our last question. And Kabir, you may be a great person to talk about this, given your background in community engaged research. And I do think that it's reasonable to have some concern that as we come in with an implementation science lens, that we're starting a conversation by saying what you're doing isn't good enough. What you're doing is not what the evidence says you should be doing. And we do run the risk of being condescending, of creating almost enemies, if you will. I'd be curious what you've seen, especially with that community engaged research lens, of how you come into this with an air of humility, how you come into this with the way of building collaborators and partners rather than coming in and wagging your finger.
Yeah. So what I would say is that that's sort of built into the process is understanding the people and the inner and outer context. And if you do that, and especially if you do it with the health equity lens, it's less about telling people what they're doing is wrong and more about like, how can we work with you to make this better, especially if you're bringing it from a patient partnered perspective. Like our patients would like us to do this. Like, let's figure this out. So that's the other part of making it seem like a thing that is partnered rather than imposed. And so some of that is understanding what their frustrations are. You may be surprised that they've been trying to, like they actually did read the literature, or they did hear about this and they actually wanted to do it. Why weren't they able to? So it's actually helping people do the right thing, figuring out what their barriers are. So you meet them where they are and you learn from them, and then you adapt what you're doing to meet their needs that also lead to that patient outcome. Because in the end, people, for the most part, are actually trying to do the right thing. They actually want to help patients. That's why we're in this business. And so if you have that lens and you have that partnership approach, then you stand a much better chance of actually succeeding.
What a great note to end it on, especially as a student, as someone who's still coming up through the process. I'm painfully aware of some of those comments you made of how sometimes it can take a half generation really of medicine until something can really reach full implementation. And I know that many of us students within SAM sometimes scratch our heads wondering, why is this not done when we go to our clinical rotations, when we spend times in the wards, things like that. So it's great to know that there is work being done trying to bring those principles into practice. And we've still got a long way to go, but certainly some great lessons to be learned from implementation science. Some great shoes to follow in here with you two taking the lead as well. So thank you both for taking the time to be with us today. And thank you to everyone who is listening in or to everyone who is watching this recording after the fact. This recording will be available on the SAM YouTube page. Hope you'll keep an eye open for future research learning series sessions. And we look forward to seeing you around the field.